Good evening, everyone. Thank you for joining us for tonight's webinar that we are calling Living with Pancreatic Cancer, emphasis on living, organized by the Florida Society of Clinical Oncology, otherwise known as FLASCO. And FLASCO is a member-supported state society that focuses on supporting and representing the oncology workforce of Florida, and they do that well. And also representing patients as evidenced by tonight. Together, FLASCO is the voice of oncology in Florida, and many of the individuals presenting and participating in this webinar are FLASCO members, and we are grateful for their support. So, introduction to myself. My name is Dr. Jason Starr. I'm an oncologist at Mayo Clinic in Jacksonville, Florida. I specialize in gastrointestinal malignancies, including but not limited to pancreatic cancer. And I am privileged and honored to be serving as the moderator and a presenter for the webinar. Our oncology experts and I will discuss the mechanisms behind pancreatic cancer and treatment options, as well as more individual focused areas such as support for caregivers and patient advocacy. Before we begin the presentations, I'd like to let everyone know that this webinar is being recorded. Hope that's okay. So that those who are unable to attend can view it at a later time. Also, your lines will be muted for the duration of the webinar. Toward the end of the meeting, we'll host a Q&A, and we encourage you to submit questions or comments through the webinar. So this webinar is for you, and so please feel free. This is an open forum. No pretenses, no expectations. Come as you are, and please feel free to ask questions. And there's a question box on the webinar panel, if you can see that, and you can type it in there, and we'll get to as many questions as we can. So in terms of the speakers we have tonight, it's certainly an honor to share the stage with them, and I will introduce our accomplished group of panelists. Please feel free to read their bios. It might take you a while, so save that for a later date. But it is in the handouts box on the GoToWebinar panel. So our first panelist is Dr. Kabir Modi, who's my close colleague and my office neighbor. He's an assistant professor of medicine at the Mayo Clinic School of Medicine and Science. He sees patients with gastrointestinal malignancies and specializes in hepatobiliary disease and cancer. Our next panelist is Dr. Peter Hossain. He is a specialist in medical oncology at the Sylvester Comprehensive Cancer Center at the University of Miami, who just got NCI designated, by the way. And his focus is pancreatic cancer. Dr. Hossain is the co-director of the Gastrointestinal Cancer Site Disease Group. Also joining is one of our regulars, Raymond Penn. He's with the Pancreatic Cancer Network, also known as PanCan. He does a lot with this organization, whose mission is to improve the lives of everyone impacted by pancreatic cancer by advancing scientific research, building community, sharing knowledge, and advocating for patients. And I could attest they do exactly that. After the question and answer, we will have the opportunity to hear from our final panelist, Dr. Michael Diaz, via a video. And Dr. Diaz joined Florida Cancer Specialists and Research Institute in 2011. He's currently serving on its executive board and as the assistant managing physician vice president. In addition, he serves as the director of patient advocacy for FLASCO and on multiple work groups for ASCO. He's also past president of ASCO and one of the most active members in the whole organization. And I think we all collectively are thankful for all of his hard work and volunteerism. So thank you, panelists, for joining us to share insight on the different aspects of living with pancreatic cancer. So to start things off, I'm going to talk about pancreatic cancer, the disease, and just generally speaking, what I wanted to really discuss is making sure that you know what to talk to the physician about and preparing you in terms of arming you with information and knowledge so that you feel informed, and that when you go to see the physician, you feel confident in knowing how to direct a discussion and what questions to ask. So before we kind of get to that, in terms of symptoms with pancreatic cancer, sometimes they can be very insidious and kind of quiet, vague abdominal discomfort, a little bit of weight loss. Some patients will have elevated blood sugars, or new onset diabetes is certainly something that should alert your physician to the possibility of pancreatic cancer. As I mentioned, weight loss. Some people present with what we call jaundice, which is yellowing of the skin and the eyes, with or without pain. So the disease can present with pain or without pain. It's very interesting sometimes how some patients have pain and some patients don't have pain. And so, I think those are kind of the general symptoms. Obviously, and a little bit more about the pain. Typically, it's in the mid-abdomen area. It can radiate to the back. A lot of patients will say it feels better when they kind of lean forward, and it's worse when they lay down at night. So those are just a few things that, just so you can teach, others about. And so when you, are diagnosed with pancreatic cancer, obviously it's a heavy diagnosis. However, the point of this webinar is to instill hope. And what we want to do is inform you that there's progress being made, that there's always hope, no matter what. And so if you take anything away from this whole webinar, is that there's always hope, and you should know that we're working tirelessly to improve upon what we have to treat this disease. So a little bit about diagnosis. Typically when we make the diagnosis, we will go to sometimes the pancreas to do a biopsy. If the disease happens to have spread, sometimes we would go into, for example, the liver to do a biopsy. And when you go to see your physician, you want to know what stage is the disease. Now, stage can be a little bit tricky with pancreatic cancer, because really we want to know, is it localized or has it spread, which we call metastatic or stage 4 disease. And if it's localized, it's very nuanced. So we call that resectable or borderline resectable, or another term we use is locally advanced. And what that's determined by is, if we could pull up the first slide on the anatomy. Perfect. So what that's determined by is this anatomy. So you could see the pancreas here is deep-seated in the abdomen, surrounded by a lot of different structures. You have the duodenum coursing around it, you have the stomach nearby, and the most important is these blood vessels. And the blood vessels determine, can the surgeon get the tumor out safely? Because a lot of times patients will ask me, well, can you just get it out? And I totally understand that mindset, and intuitively that makes sense. But the surgeon has to make sure that they don't damage blood vessels that are vital to the organs of the bowel. And so when we determine the resectability, or whether or not the disease can be removed or surgery can be done, it is critical that we look at the vessels that are involved. And how do we do that? Well, the most common way is a CT scan. But make sure it has to be something called a pancreatic protocol. They have to do an arterial phase and a venous phase, meaning you have to really see the tumor in relationship to the blood vessels. Now, at Mayo Clinic, we use a lot of MRI. We really rely on MRI. It's quite impressive with some of the images we get and the definition in relationship to the blood vessels. So we use a lot of MRI, but I'd say we were the exception as opposed to the rule in terms of that initial diagnosis. We typically do not do a PET CT scan for this disease. It's typically not helpful, but you do want to include a CT scan of the chest, and again, imaging of the abdomen. So once with your physician, you've established, is this potentially, can we have surgery? the treatment approaches have really evolved over the last few years. And before, we would determine if surgery is possible, patient would potentially go to surgery, and then afterwards we would deliver the treatment, whether it be chemotherapy or radiation. We've really shifted the paradigm to deliver the therapy on the front end, okay? And the medical kind of verbiage for that is called neoadjuvant. I'm not going to quiz you on that, but neoadjuvant means giving it before the surgery. And so typically we try to give the chemotherapy, maybe the radiation, before the surgery. And what that does is helps ensure the surgeon can get all of the cancer out. We also know that the disease has a high propensity or a high common, it's very common for the disease to spread. And so the chemotherapy tries to kill the cancer cells that may have spread outside of the area of the pancreas. And so that is the rationale for giving the chemotherapy. Now, we would like to see shrinkage of the tumor, but that doesn't always happen. And that's really actually more the exception than the rule. And so that is part of the treatment approach. And that's sometimes hard to, I think, understand in that, okay, you could take it out, but you're going to wait potentially 4 to 6 months, and you're waiting all this time when you could just get it out. And it's important to recognize that if the surgeon goes in there, we have to make sure that we do the job right. And so, that is why we give the treatment up front. We have improved upon outcomes, survivability of the disease. We've decreased the morbidity or the complications after a surgery. We've decreased the complications of radiation and chemo. Everything's getting better. Now, I wanted to talk a little bit about the surgery. I'm not a surgeon, and I don't pretend to be one in real life. And so if you could just pull up the next slide, please. So what I wanted to highlight is we talk a lot about the Whipple procedure, right? Named after a famous surgeon. And I wanted to kind of highlight some of the anatomical changes that occur with a Whipple. So as you can see here, this is the pancreas and the tumor is intact on the top. I don't know if you could see my cursor, probably not. And then in the lower right is a picture after a Whipple. So you can see the structures that are removed are the duodenum, which is right next to the pancreatic head, is the gallbladder, which is removed, and you can't really see it much there. And then there's a lot of rerouting of your organs. So your pancreas now directly communicates with your bowel. Your bile ducts directly communicate with your bowel up here, where they pull up a loop of bowel to connect it to. And then your stomach is also redirected because you don't have a duodenum anymore. And so, they've gotten so good with this surgery that, a lot of patients can live a normal life after this. And one thing that is worth mentioning is some patients do require to go on insulin or diabetes meds afterwards. And another symptom that I didn't touch on too much on presentation, but one that should be noted is something called pancreatic insufficiency, or more specifically pancreatic exocrine insufficiency, where the digestive enzymes that are in the pancreas are released normally and digest your food, namely your fat and your carbohydrates. But fat mainly is really those digestive enzymes are really needed for fat, breaking down fat. So patients who don't have those digestive enzymes, or enough of them, or after surgery you just don't have enough pancreas remaining making those digestive juices, or enzymes I should say, we sometimes have to replace them with pills. Now, how do you know if you have pancreatic insufficiency? You have a lot of gas or bloating after eating. You have to go to the bathroom right after eating, and the stool floats on the surface. It's kind of oily. Don't want to get too graphic, but that's how it goes. And so you want to be on lookout for that, and alert your physician if your physician doesn't alert you to that being a possibility. So those are kind of some of the rerouting of the anatomy. Some of the complications thereafter. Sometimes the stomach can be a little slow to kind of start working, but typically it picks up. And some patients do have some chronic pain, abdominal pain after the surgery. It can be difficult to treat, but at least worth noting. So this is when the tumor's in the pancreatic head, we call it. And then if we look at the next slide, when the tumor's in the pancreatic tail, you can see this the dotted line here. This is where there and beyond the tumor would be removed in addition to the spleen. So that's called a distal pancreatectomy along with a splenectomy. So it really depends on where the tumor is that dictates what kind of surgery is done. You want to see a surgeon who does these surgeries day in and day out at a high volume institution. And that's really important to emphasize as the literature shows that there's definitely decreased complication rates at places that do these surgeries often. So we'll pivot a little bit and talk about the treatment. And when the disease is not potentially surgical, they can't remove it, the mainstay of treatment is typically chemotherapy. We do incorporate radiation therapy sometimes for either pain control, sometimes to give patients a break from chemotherapy. You have to be able to target an area to do radiation. Typically, it's the pancreatic tumor itself. And so the mainstay of treatment is chemotherapy. There's two kind of main regimens that we use. One is called FOLFIRINOX. I won't get into too much of the nitty gritty on that. And another regimen is called gemcitabine and Abraxane. So those are the two main regimens. Now, I think it's very important to emphasize another take-home message. First one was hope. Second one is genetic testing. Every patient with pancreatic cancer should have genetic testing, both of their own DNA and the DNA of the tumor. Please, if you haven't had that done, please ask your physician to do that. It could have implications for you and your family. It could have implications for your treatment. Very important to do that. If we're going to make advances, if we're going to, make an impact, sometimes we need that information. And so please emphasize that with your physician. And we are going to have some experts talk about the genetic testing and then some of the genes that can go awry within the pancreatic cancer. By definition, cancer is a disease of the genes. Something goes wrong in your genes. You have 23 chromosomes and you have pairs, so 46 total. Something goes awry. And Dr. Hussein will talk about that. Now, one other point before maybe we take a few questions is clinical trials. At every stage of your treatment, please, if your physician doesn't bring it up, ask about clinical trials. Where can I find a trial? Am I eligible for a trial? What is a clinical trial? And Dr. Modi is going to talk a little bit about, what a clinical trial is and what that entails. PanCan has an excellent resource, and maybe Raymond will talk about it a little bit, where they will help you find a clinical trial close to you, if there is one. The only way we can move the field forward for you is clinical trials. I think clinical trials should be discussed at every stage of the treatment, at the beginning, the middle, every stage. So I was alerted that we're actually going to take questions at the end. So please write your questions in the little box there and submit them. I'd love to have a dialogue with you. So now that we've reviewed the disease, kind of in a nutshell, I'm going to turn it over to Dr. Modi to turn on his camera, and I'll turn off mine, and discuss the importance of clinical trials and the clinical trial phases. So thank you, Dr. Modi.
Hello, guys. How are you? Thanks to everyone for joining us tonight. Fantastic to see so many people out there. So, and thanks to Jason for that fantastic overview. So, yeah, we're going to talk about some aspects of clinical trials, and the way I'm going to approach this is basically as a sort of clinical trials 101 for you guys, so you can know what you're looking for and know what looking at when you're looking at all these lists of trials that you see on websites for a number of our academic institutions, or even PanCan in their clinical trial finder. So next slide. Okay, so we're just going to review the process of how clinical trials works. Next slide. So, you know, thanks to the largely to the efforts of advocacy groups, you know, for pancreas cancer, like Pancreas Cancer Action Network and Lustgarten Foundation and others, you see that the funding at the government level for pancreas cancer research has gone up tenfold since 1999 through 2017. But this is just government money. Funding for research occurs. It comes from advocacy groups. It comes from non-government organizations and patients too, who donate largely to advocacy groups and institutions as well as benefactors. So all this money is really important to support ongoing work and trials. Next slide. And you know, with an increase in funding, you increase the amount of knowledge we have about a disease, and generally increase in the number of breakthroughs that are made and clinical trials that are done. And so you see the number of clinical trials rising over time. These are a number of clinical trials that are actually being published. Next slide. So here's kind of a general overview of the research process and how you know we do things in the medical field here. So generally, you start with an idea and you look at it in the lab. You might be looking at it in petri dishes of pancreas cancer cells, trying to explore different biologic mechanisms of the cancer and the cells that lie around the cancer. If you hit on something, you might, you know, escalate that study to mice, and we could do studies in mice where we cause them genetically to get a pancreas cancer, or take cells from a petri dish and inject them into mice and allow them to grow, or to even take patient tissues. Sometimes we'll do biopsies with patient consents. And take their tissue and run it over to the lab and put it under the skin of a mouse or in the pancreas of a mouse and let it grow into a tumor. And then we can use those to test different hypotheses. And once we find you know, a potential idea that works, we'll start off with a small study to assess it preliminarily, and then expand to larger studies. And we're going to go through this process a little bit more in detail here. Next slide. So again, it starts with an idea, and that idea has to be tested rigorously in lab research to prove a hypothesis. And you know, this is where a large amount of funding goes to support these lab studies, to do all sorts of really cool and innovative and explorative work in the lab to really understand the biology of the disease and come up with ideas of how to treat it. Next slide. So I'll take you through kind of an example of how we go from an idea to an approved therapy. And so this was one of the initial studies on a drug called Abraxane or nab-paclitaxel, which many in the audience will know, which is now today as a standard treatment used for pancreas cancer. But not so long ago, it started out in the lab, and Dr. Tuvison in his lab thought that maybe this novel formulation of paclitaxel would help us to potentiate the activity of what was prior the only known effective treatment for pancreas cancer, which was gemcitabine. And so they looked in the lab at the anti-tumor efficacy and the molecular mechanism of Abraxane in combination with gemcitabine. They showed that in mice and in cell lines, the Abraxane actually increased the amount of gemcitabine in the tumor, and in combination as opposed to together or separately, the combination worked much better at slowing and shrinking tumors. All right, so stay tuned to the story. We'll keep coming back to it. So a clinical trial is basically we're using human volunteers and participants and patients to increase our medical knowledge about whatever we're studying, right? And there's two types of main clinical trials. One is observational, where we're basically enrolling you to collect information about how your disease developed or how it goes on particular treatments, or you know, any sort of little particular feature that we want to look at, whether it be looking at something to see if it helps us predict treatment responses better or whatnot. And then the second is one of the more common ones, which is interventional. So this is basically where we're enrolling patients who are actually doing something with them. So giving them a specific treatment, doing a specific radiology test, perhaps, you know, testing something which takes action on the part of the patient or the patient is participating actively in. Next slide. So patients receive specific in interventional studies, which we'll talk about from here on out. Participants will receive specific interventions according to the research plan or the protocol that's created by the investigators. So when Dr. Starr writes a clinical trial for a novel treatment for pancreas cancer, he will write this out in painstaking detail, kind of like an owner's manual, so that everyone who's participating in that trial and treating patients on that trial does things the same way, informs patients the same way, and everyone is following the rules and doing things in a standard way, so we can make comparisons accurately and get all the information out that we want to get out. Next slide. Interventions could be medical products such as drugs or medications, procedures such as surgeries or biopsies or whatnot, or even changes in participants' behavior. So studies like, well, what if we have patients follow X diet versus Y diet? Will that make a difference? Next slide. And the goals, so in early, so the goals of clinical trials basically are a couple, right? We want to find what is the right dose and what is the safety profile of a drug if we've never given that drug to humans or limited human experience. And then ultimately, we want to figure out what is the efficacy of the drug or the combination of drugs, and evaluate the efficacy against the safety to assess whether we should move it forward and ultimately whether the FDA should approve it or not. Next page, next slide. So there's a lot of unknown when you participate in a trial, and patients deal with this all the time. You know, there may be an unknown, there's definitely an unknown of whether the study treatment is going to work better than the standard for you, whether it's going to be safe for you. In a randomized study, maybe whether you're going to get randomized to the standard of care or whether you're actually going to get the study drug. A lot of unknowns, and you know, this is part of participating in a clinical trial. And as physicians, we try to give you the best knowledge that we can about the drug and our honest opinion about whether we think it's worth it to go on that study. And there's always equipoise in these in terms of ethical decisions. So when we're designing these studies, we definitely, the ethics of how the study is conducted is a huge part of this. And you know, we want to make sure that patients are safe and doing something reasonable and not something unethical or totally off board. Next slide. So the development of trials usually proceeds along different phases, phase 1, 2, and 3 mainly, and we'll go over those here next. Next slide. Okay, so these are the phases of clinical trials. So we talked about the exploration phase that we do in the lab. And then we have phase 1 trials, which are mainly dose-finding studies and safety. Phase 2 trials, which are preliminary proof of concept studies. And then phase 3 trials, which are ultimate comparative efficacy studies, looking to get drugs approved and more standardly in the clinic for patients. Next slide. So again, phase 0, these studies are not very often done, but they might be very limited human patient enrollment, looking at preliminary information about how the drug behaves in the body as a way of justifying further study. These are really exploratory. I would say that it's pretty rare that we do these, but next slide. So one study that you guys might come across when you're looking at trials for you yourselves or your loved ones or friends are phase 1 trials. And these are really important studies. So these are really the first foray that we get, you know, for novel drugs or novel combinations of drugs into patients. The primary goal is to look at the safety and the safety profile of these drugs, so we know, you know, sort of what to expect going forward in the development of the drug, and also really whether it makes sense to whether that drug is really worthy of being in the clinic and protecting patients. We also want to evaluate different blood measures and tissue measures of the drug. So we want to verify what we've seen in the lab. Pharmacokinetics deals with how the drug is broken down by the body and how long it hangs around in the body. Pharmacodynamics deals with how the drug is working in the body. So if we are expecting the drug to hit a specific target based on our study in the lab, then we might do pharmacodynamic studies in patients who are enrolled in these trials to prove that it's hitting that target, or to explore whether it's hitting any other target. So phase 1 studies are going to have, you know, a good number of blood draws to look at these pharmacokinetics and pharmacodynamics. They might have a couple different tissue biopsies, so opportunities to biopsy the tumor before you take the drug and after you take the drug to do further study back in the lab and explore the drug even further. Next slide. I will say phase 1 studies are generally not randomized, okay, but the drugs that are used there are, not as experienced in humans. They are set up in a way where they enroll a few patients and then they close temporarily and then they open again. And the reason they close temporarily is because they're evaluating the safety really carefully in the patients that were just enrolled in order to justify whether they should go on or not. Phase 2 studies gather preliminary data on effectiveness and further data about safety. They might be randomized, but more often than not, they're not. And they're enrolling a slightly larger cohort of patients to explore these things. Next slide. So back to our Abraxane and gemcitabine story. So after that initial data was done by Dr. Tuverson's lab, they realized that this should be explored further in the clinic. So they actually combined doing a phase 1 and a phase 2 study. So they basically enrolled a few patients in the phase 1, and then they expanded and opened the study to even more patients in a phase 2 study. So you can see here again, primary objective was to find the maximum tolerated dose. So enrolling patients at different doses of the Abraxane drug to find which dose was the best tolerated or maximally tolerated, and then to provide initial efficacy and safety data. So they had 3 doses that they explored, and ultimately they found that there was a signal of efficacy here and that it should be explored further. Next slide. So phase 3 studies these are the big ones, okay? So these are primarily looking at the effectiveness of drugs in different populations or different combinations, and really rigorously testing the effectiveness. And these are usually randomized. They are either randomized against placebo, which is basically a sugar pill or a non-effective tablet, or they're randomized against standard of care. So, and we'll see an example of this in a moment. So, if a lot of patients are worried about being randomized to placebo, and rightfully so. Most of the time, in a case like that, you won't know whether you got the placebo or not. And this is basically to satisfy particular statistical rules when we're designing these studies, so we really can make rigorous comparisons without any bias from inadvertent, excuse me, purposeful or inadvertent to try and tip the scales. But again, usually very rigorous studies done to finally explore efficacy in these drugs. And the ultimate goal is for FDA approval. Next slide. So back to our example, this was the phase 3 study. And again, so they had gone through a phase 1 and phase 2 trial where they determined the most appropriate dose and shown that it was effective. So now we're going to go into a larger study where basically they were randomly assigned to get Abraxane with gemcitabine or gemcitabine alone. And at the time, gemcitabine alone was the standard of care for patients with pancreas cancer. So if you were a patient coming on this study, you were randomly assigned to get the combination of the 2 drugs or one drug by itself. And you likely did not know which arm you were in. And the primary endpoint was, again, overall survival, looking at other stuff as well, but primarily overall survival. Next slide. Phase 4 studies might be larger studies done after the FDA has approved the drug. And the FDA might require these to gather additional information about a question about a particular safety or efficacy question that they might have. Not very common that we see these, but possible. Next slide. So a couple more slides here. Again, these trials are led by a principal investigator who's usually a physician like myself or Dr. Starr or Dr. Hussein, who's conducting a clinical trial at their site. And they have a research team supporting them, nurses, research coordinators, etc. And they're all the team that's making sure that the trial is conducted properly and safely. Next slide. Who pays for these? So they can be paid for by governmental agencies, or they're more commonly paid for by pharmaceutical companies who are supporting the development of these novel drugs and the research that goes behind them, they need to pay for these studies to prove that they work. Next slide. The length of the study really varies based on what's being studied, but in general, patients are told how long the study is going to last before they're actually enrolled, the study usually lasts. If you're on treatment, ethically we're obliged to provide that treatment for you free of charge as long as it's working for you. Okay, so that's generally stipulated in the consent form. How much time do I have left, Daniela?
Dr. Modi, you have 10 minutes.
Okay, next slide. Okay, so when you go to sign up for a trial, what the research team is going to do is they're going to assess whether you're eligible for the trial or not. Remember, we said that it was a protocol that stipulates everything about the study. So they will clarify, the protocol clarifies who is eligible for the study, down to specific lab values that we want to see, prior history of other diseases or other cancers, or prior treatments that you've gotten for your cancer, and that sort of thing. So there are, these are basically the standards outlining who can participate. There are inclusion criteria, there are exclusion criteria. So if you meet any of the exclusion criteria, you're not eligible for that study. Okay, so these are really important to look at, and are generally, at least in part, included in clinicaltrials.gov, I believe, for a lot of studies, so you can look and see what these are about. But generally, when you go in to participate in a trial, we're going to tell you all about the trial, about the safety part of the study, the safety risks, what's entailed, the schedule, everything about the study. Once you sign on to participate, we're going to do perhaps a bunch of labs and other tests, all trying to determine whether you meet the eligibility criteria or not. Okay, next slide. So here's the informed consent. This is really important. This is how we, in one way in which we protect patients and make sure that they are informed about the study and all the stuff that goes along with it. We're providing potential participants with information about that study. It should provide enough information for you to understand everything about that study. Again, the risks, the potential benefits, alternatives, schedule that's expected of you, what's going to be done from treatments to blood draws, everything. That the information can be provided to you in a number of different ways. You should have the ability to ask questions. You should have the ability to review it on your own time. And once you're ready, sign that informed consent to officially enroll in the study. It is not a contract, meaning you're not signing on to the study and you can never come off once you sign. You are the boss. You can come off the study whenever you want. again, you're not signing a contract. Next slide. Again, we're big on making sure that ethically these studies are done properly. Every institution has an institutional review board whose sole job is to evaluate clinical trials and other studies being done with human involvement, to make sure that ethically they're doing the right thing, that they're protecting patients, and they're safe about doing it. Next slide. There are also data monitoring committees who are, perhaps external persons who will review the study data at particular intervals, and have the authority to stop a trial if it's deemed that the investigative treatment is not safe, or if the trial is not being done properly, they can stop it for any reason. Okay. Next slide. The benefits of participating in a trial, of course, are contributing to medical knowledge, and some trials may provide you with a treatment option that you didn't otherwise have. And it's possible that treatment option provides a great benefit for you, particularly in terms of your disease. Next slide. Of course, there are risks. You're entering into a world of unknowns, as we talked about before. Depending on which phase of the trial of study you're entering, you could be entering at a phase 1 stage where there's not really a lot of information about what the safety is of this drug or the efficacy, or you could be entering in a phase 3 study where we have prior clinical trials in humans of that drug, and we can draw on that experience to inform you about safety and that sort of thing. So there are risks. But again, ethically, we're obligated, before we even open the study, to evaluate that study for risks and make sure that they are as minimized as much as possible in terms of being reasonable in terms of the anticipated benefits. Next slide. Next slide. Next slide.
So is that might be the end there, Dr. Modi, or is there a few more slides? Yeah, this is the last slide.
That's it. So basically I just wanted to provide an update, again, clinical trials 101, so you understand a bit more of the nuts and bolts, because it really is a world of unknowns, and can be scary to navigate these. But we're all here to help you evaluate studies together and explain things to you as you make the journey. So thanks for having me, guys.
Thank you, Dr. Modi. That was excellent overview. From conception to bringing a medication to the clinic. Obviously, takes a lot of work and a lot of effort. And at the end of the day, we really appreciate you, the patient and caregivers, for supporting and being selfless by supporting research and helping us help you. So thank you. We always know the bottom line is always you when it comes to research and everything we do. So please, you guys are putting questions in the box there, so appreciate it. Some really good questions. Excited to get to those. But until then, I'm going to turn it over to Dr. Hussain, who is going to talk to us about genetic testing, one of the key take-home messages I hope you get out of this. And we're looking forward to Dr. Hussain's talk here. Thank you.
So thank you very much, Dr. Starr, and to the organizers of this meeting, the Florida Society of Clinical Oncology, and also to the sponsors, PanCan, and I think Epson is one of the sponsors as well. So it's really a privilege to be able to share with you all some information on this day, which is the World Pancreatic Cancer Awareness Day, and of course we're in the Pancreatic Cancer Awareness Month. So it's really important to get the message out, not just to people on the call, but to the general population about what's happening with pancreatic cancer, because there've been, this year we lost a number of people who are prominent in society to this disease, and apart from people who are famous, I've had many new patients diagnosed with pancreatic cancer this year, and it seems like in my estimation, and every year you see the statistics where the number of new cases is going up. So really, people like Dr. Starr and Dr. Modi and myself are really passionate about this disease, and we're doing the best that we can to improve outcomes. So I'm going to talk a little bit about genetic testing. So if we can go on to the next slide. So we are now doing genetic testing routinely for all new patients with pancreatic cancer. So this is something that when I started probably about 12 years ago, we didn't really have any concept of this. This is something that has really taken off, I would say, in the last 5 years or so. And we know that genetic testing has been around for some time. People were testing for genes like BRCA for some time now for breast cancer and ovarian cancer, but it has now become mainstream for pancreatic cancer. And this is very important for patients to understand. And, many oncologists 10 years ago didn't know a lot of the lingo that went along with genetics. And definitely, if you ask patients what germline means, most patients would not know what that means. But now I think most of my patients know what that word means. And, this is something that we spend a lot of time discussing with patients. When I see a new patient, I spend a significant chunk of time explaining this concept to them. And this is something that makes a huge difference in some patients. So there are two types of genetic testing, right? So I usually explain it to the patients by saying that I'm doing a test on you as an individual, and you can do a genetic test on someone whether they have a diagnosis of cancer or not. And people do this, very commonly. You go on a website like ancestry.com, or you do go on College Genomics, and you can order a test kit. They send it to you, and you send a saliva sample back to them, and then they come back and tell you that you are 90% Caucasian or 90%, whatever. So that's one application of genetic testing. So how we apply genetic testing, what we refer to as germline testing, is we want to find out, first of all, if there's an explanation as to why somebody developed pancreatic cancer. So a lot of people, have very healthy lifestyles, and they are active and they eat healthy, and they still develop pancreatic cancer. And a lot of people ask, well, why did this have to happen to me, right? So the genetics sometimes can give us the answer to that question. But really, it's not only for curiosity. The reason why we do this test is twofold. One is to identify whether there's a risk in the family, because we now know that there are programs that we can apply to patients, family members who are at high risk for pancreatic cancer. And if we detect the disease early in a screening program, that can make a huge difference in survival. For example, there's a program that was really developed and pioneered by the Hopkins group called the Cancer of the Pancreas Screening Study, CAP study. And they started many years ago and developed a group of patients who were families who were high risk. And they started doing MRI scans and endoscopic ultrasounds alternating every year. And they found that they were able to detect cancers early in these people who were high risk, or families who were high risk. And if you were detecting them early, the 5-year survival was close to 80%. So most of you on this call will know that the 5-year survival for pancreatic cancer right now does not stand at 80%. But if you can screen a high-risk group, you can really make a huge impact on survival. So even though you are telling somebody that their family may be at high risk, you can also offer them something that can reduce that risk, or try to pick up something early. And of course, screening for pancreatic cancer is not available for every person out there. The risk of pancreatic cancer in the general population is relatively low, and we don't have a screening test that can be applied to somebody who is not at high risk. But if you identify a family at high risk, then doing screening can help. So that's one use. We have patients who have children and they want to know, are my children going to be at risk? And this is one way of finding that out. Secondly, some mutations now that are inherited in families make a huge difference, not just for the family, but for the individual patient. So the example that comes to mind readily in pancreatic cancer is the BRCA mutation. So BRCA initially, it was defined as a breast cancer associated gene. And we now know that BRCA1 and BRCA2 are associated with increased risk of breast cancer, pancreatic cancer, ovarian cancer, prostate cancer, as well as bile duct cancers to some extent. Of course, breast and ovarian is the most common, but we see a significant chunk of patients with pancreatic cancer with BRCA mutations. And we now know that patients who have a BRCA mutation have more sensitivity or may be more responsive to drugs like platinum drugs. So chemotherapy previously was sort of a blunt instrument. We would give chemotherapy to every patient and hope that they would respond. But now we can say, okay, well, this patient has a BRCA mutation, so probably oxaliplatin or cisplatin might be a better drug for them. And there are now many different groups that have described success using that approach. And how I use that information is if I have let's say we have an elderly patient who has a new diagnosis of pancreatic cancer, I think the field in general most oncologists would recommend a more tolerable regimen like gemcitabine and Abraxane in patients who are older, because that one you can tweak and it's a little bit easier to tolerate in older patients. But if I have an older patient who I think may have a BRCA mutation or a mutation similar to BRCA based on their family history, or if we know that they have it, then I may not recommend gemcitabine and Abraxane in the first line. I may recommend a platinum drug like gemcitabine and cisplatin, or some modification of FOLFIRINOX. So that's how we are using this information nowadays to try to select in the front line which is the best chemotherapy. And then we know now, and I'll get to this on the next slide, that there's now an oral medication approved for patients who have BRCA mutations. That's a medication called olaparib. So those are the two main advantages of having this information, right? That you can help the patient, but you can also help the family gain knowledge and maybe reduce the risk or intervene early if you can detect a cancer early. So the second type of testing that Dr. Starr alluded to earlier is genetic testing, or what we refer to as genomic profiling or somatic profiling on the tumor biopsy. So the tumor itself is sort of a foreign invader in the body. So the genetics of the tumor may be different from the genetics of the rest of the body. And we have, simplistically, you can think about it as acquired mutations in the tumor that causes these cells to turn rogue or to start growing uncontrollably. And knowing the genetic panel of the profile of the tumor, what we call the molecular profile, can help us identify vulnerabilities or weaknesses in the tumor. So the job of your oncologist really should be to be a detective to try to figure out if there's any weakness in the tumor and if you can use that to exploit that for treatment. And that's what we do every day now. I think almost every oncologist in the country would do this. Of course, there's some people who are more knowledgeable and have more experience in doing this, but this is something that I think is routine now. And in fact, most organizations like the American Society of Clinical Oncology and the National Comprehensive Cancer Network recommend routine germline and somatic profiling in patients with advanced pancreatic cancer. So can we go to the next slide, please? So this is just one slide on germline testing. So it's relatively common. I would say 1 in 10 patients, sometimes we find a germline alteration or inherited alteration. Germline again means inherited. And the most common would be BRCA1, BRCA2, and a gene called ATM. So about 5% of all patients with pancreatic cancer would have a BRCA1 or 2 mutation, and that proportion is higher in certain ethnicities, such as patients of Ashkenazi Jewish descent. Very rarely we see other mutations like PALB2. There's some enzymes involved in DNA health, such as MLH1, MSH2, listed there. those are less common to find in patients with pancreatic cancer. But if you find that, those can make a big difference in treatment as well. And the diagram that you see on the bottom of the screen actually is a schematic for the trial that led to the approval of olaparib. So this trial was called the POLO trial. And this trial recruited patients with advanced pancreatic cancer with BRCA mutations. So this trial actually screened 3,000 patients. So to give you an example, in our institution, we screened probably about 50 patients to identify 4 of them who had BRCA mutations. And we actually enrolled a couple patients on this study. And one of the patients who was on the POLO trial is still on the study therapy right now. And we believe he's getting the actual, it's a placebo-controlled trial, but we believe that he's still getting olaparib, even though it's still blinded. And it's 4 years now since he started the treatment and has no evidence of disease. His tumor marker level is normal. And you know, these are the kind of things that we've seen with patients who receive olaparib maintenance. So how was it given? Well, the study required that patients get chemotherapy first for a few reasons. One of them is that the chemotherapy is really the standard of care in the frontline setting. So I tell all patients, you know, a lot of patients come to me and they say, well, is there anything else besides chemotherapy? Can you do immunotherapy? Can you do targeted therapy? I heard a lot of bad things about chemotherapy. And what I tell them is all the patients that I have who are long-term survivors, and I'm not sure if any of them on the call today, some of them told me that they were going to register, but all the patients of mine who are long-term survivors have passed through chemotherapy. So even though chemotherapy is not fun and we don't enjoy giving chemotherapy to patients, it's a necessary evil, and you can get to the goal, you know, and we usually give sort of an intensive induction period for a few months to try to get the disease under control. And if you have a BRCA mutation, then you can go on olaparib. And in this study, patients were randomized to receive olaparib or placebo, and the patients who received olaparib had a longer survival. So this is what led to the approval of olaparib. Now, the good thing is that there are other mutations besides BRCA which appear to be sensitive to olaparib. And in other cancers, such as ovarian cancer and prostate cancer, the mutations don't necessarily have to be inherited mutations. They found that sometimes acquired mutations or somatic mutations in BRCA or genes similar to BRCA still can sometimes predict for response to olaparib. So that studies like that are ongoing in pancreatic cancer to try to expand the eligibility for patients receiving olaparib. So, for example, there was a study conducted recently called a BRCA-NIST study, so including mutations which are similar to BRCA. And you know, those results are still pending, but I have some patients who are in that study, and we've seen some responses in patients. I'm going to show you one example in a minute. So the germline testing can give us a lot of information and very useful information that can help patients. Next slide, please. I think I had a slide. Well, we can show this. So I thought I had a slide on somatic testing, but the somatic testing, well, before I get into this, somatic testing, as I said, can give us information about the tumor genetic makeup and really tell us about vulnerabilities. And in this particular patient, when he was diagnosed in June 2017, the Pancreatic Cancer Action Network had this program ongoing called the Know Your Tumor program. So really we have to thank PanCan for pioneering this work where they sponsored genetic testing, both tumor testing and germline testing in approximately 1,000 patients with pancreatic cancer. And they did this at no cost to the patient. And this has given us a wealth of information about the disease and about treatment options. So this patient actually had their tumors sent out to the company that was doing it for PanCan. And they actually came to me after the first visit. They had already set it up. And I got the results after he already started chemotherapy. So we started, this is a patient who was diagnosed in 2017 with pancreatic cancer involving the pancreas, liver, and lungs. And we started this chemotherapy regimen called FOLFIRINOX, which some of you may be familiar with. And he had the testing done. So next slide, please. So this is his course, and I'm using his tumor marker levels to show you what happened to him. So the curve is showing you a high tumor marker level on the left, and this is a CEA. This patient was not a CA19-9 producer. So CA19-9 is a more common tumor mark, but some patients don't make that. And he was producing CEA. So his levels started out about 180, and after starting FOLFIRINOX, his marker level dropped very nicely. And he was enrolled on this study, the BRCA-NIST study, because of a mutation that we identified called RAD51C. And the RAD51C mutation is a mutation associated with an increased risk of ovarian cancer. Hasn't really been described with pancreatic cancer, but we believe that this may have influenced his development of pancreatic cancer. And we're actually doing some more detailed testing on him to figure out if this really was responsible, or if we can find more evidence to support that. But he was placed on olaparib, even though he didn't have a BRCA mutation, and had approximately 12 months of benefit from that. And eventually, after about a year, his tumor marker levels started going up a little bit. And we can go to the next slide. He was then placed on chemotherapy, right? So we gave some standard chemotherapy treatments there, and we kind of intensified the treatment because he started becoming more symptomatic, started having very severe pain. So usually we go from more intense chemo to less intense chemo, but this patient was fit. So he was able to handle 2 different triple chemotherapy combinations, but did not respond. By the time we got to July 2019, which was last year, 2 years after his diagnosis, he was in very severe pain. He was taking 2 different pain meds. And, you know, I thought that this was coming down to the end of the line. In fact, one night his wife called me, and I was already asleep. She left a message saying that he's lethargic. And the next day I tried calling back, and they were not answering the phone. And I honestly thought that he had died that night because of how sick he was. So based on what we knew about his genetics, we were running really out of options. I didn't have a clinical trial to offer him at that time, and he was really getting more debilitated and may not have been a candidate for clinical trial at that time. So this was sort of a Hail Mary, you know. We didn't have much options. So next slide. Next. So we treated him with a combination of 2 immune checkpoint inhibitors. So these are immunotherapy drugs which are in the market, and they are approved for melanoma, for kidney cancer, for a few other malignancies, but they're not approved for pancreatic cancer because generally they don't work in pancreatic cancer. People have tested these drugs in pancreatic cancer and similar drugs, and really in unselected patients, in patients where you don't know their genetic makeup, if you give these drugs, they just don't work. Now, this particular patient, the reason why we thought that this might be a potential treatment option is because he had this RAD51C mutation, which behaves similar to BRCA. And what we found was that led to a little bit of genetic instability of his tumor. So it didn't result in something called microsatellite instability. He did not have that, but he had a tumor mutation burden, which is a little bit high. So if you look at a genetic profile, you get this result called a tumor mutation burden, or TMB for short. And the TMB in most patients with pancreatic cancer is around 0 or 1. I get deflated every time I see a genetic sequencing report and they come back with a TMB of 0. This patient had a TMB of 8, which is not very high. And more recently, there was an immunotherapy drug called Keytruda or pembrolizumab, which was approved for any patient with any cancer with a TMB greater than 10. So his number was 8, and we didn't think that was very high, but we really didn't have any other options left. So we treated him with this treatment, and this was more than a year ago. His tumor marker level normalized. Within 3 weeks, he was off all his pain medications, and he now has achieved a complete remission. So this is an incredible response, which was just based on an idea or hypothesis really born out of his genetic testing. And I can tell you without a doubt, if this patient had the same problem 5 years ago, he would have been dead already, because we didn't know about this at that time. The drugs were not widely available, and the genetic testing was not widely available. So having seen a situation like this, now I want this to be every one of my patients, right? So we have to I look, and in fact, I have some patients who come to me and they bring their genetic testing report, and I say, well, this doesn't look consistent, or maybe this test was not very reliable, because if the report says that they did a genetic sequence on a tumor, which was 20% tumor cells and 80% whatever stromal cells, or the report sometimes tells you what the purity of the biopsy is, then I say maybe we should do a new biopsy to get a new genetic test. And sometimes that yields results. I had a patient recently who came to me with a germline profile from a company that was a very limited panel. And I said, maybe we should repeat this using a wider panel. And we did find something that we were able to act on when we repeated it on the wider panel. So you have to have a high level of investigative spirit to be able to pick up things like this and be able to kind of step out on a limb sometimes when your back is against the wall and you don't really have any options. So this is, in fact, there was an article in the New York Times about 2 years ago, I think, called The Investigative Oncologist, and describing, I think it was Sid Mukherjee who wrote that article, talking about, trying to uncover any little vulnerability of the cancer to try to do it. And it's off-label therapy. Sometimes you do compassionate use, and people argue about whether that is beneficial. But for this patient, there's no argument, right? If you were this patient, you would say, medicine and science really helped him to be alive today, almost 18 months after he was almost dead. Okay, so next slide. So this is where we are right now in terms of personalizing cancer therapy based on genetics. So there are some approved therapies which are referred to as tumor agnostic. So some of these treatments on the left column for microsatellite high, MSI high, NTRK fusions. These I'm not gonna quiz you on these things afterwards. TMB high, those are for any cancer. And then for pancreatic cancer, if you have a BRCA1 or 2 inherited mutation, you'll be eligible for olaparib. But we believe that there are other mutations where olaparib may be effective as well. And then we frequently do off-label therapy if we don't have any options, if the patient can't travel for a clinical trial, if we don't have a clinical trial available. If we find a genetic weakness in the tumor that is validated in other cancer types, for example, HER2 amplification is validated in breast cancer and gastric cancer, and we can use drugs borrow drugs from other cancers and use them, and sometimes we've seen successful outcomes in those situations. So, of course, we still have a long way to go because most patients come back with negative genetic testing, and of course, people are working on approaches which are not genetic based on mutation profiling, but based on other types of signatures like immune microenvironment signatures and this kind of thing. So, even though this is not beneficial for a lot of patients, it really makes a huge difference for some patients. So it really is important to understand these concepts. And, of course, if you're a patient listening to this, you really have to talk to your oncologist about this and push them a little bit to make sure that they can offer you innovative treatments if you're eligible for that. So I would like to stop there and thank you very much for your attention, and I'll hand it back over to Dr. Starr.
Thank you, Dr. Hussain. That was excellent. I really enjoyed it, and I know the audience did as well. I love that you highlighted, a case of a patient and instilling hope for others that could have these therapies. And again, you're not going to find them, these mutations and all of these alterations, if you don't look. And so I think Dr. Hussain highlighted that wonderfully. So next, I want to turn it over to Raymond Penn, and he will discuss patient assistance programs and caring for the caregiver. So thank you, Raymond, for joining.
Thank you. Thanks. It's great to be here. PanCan, those were some kind words, Doc, for all the things that PanCan has done. And I'm going to elaborate and add a little bit more to it. PanCan has been helping patients and families affected by pancreatic cancer for over 20 years. And all of our programs and services are offered for free of charge. The Patient Central is a one-stop shop for people facing this disease. People can go, they can call, or they can email and get free information. And the information they'll get is like a list of the cancer specialists in their area, a personalized clinical trial search, it'll help them do that, diets and nutritional information, local support groups, and other resources like financial assistance that may be specific to where they're living at that time. It also has free educational packages that can be mailed out to them to help them make some critical decisions. Now, PanCan also offers some free resources and materials to healthcare professionals. Those can be ordered online, free at https no-click meal at www.pancan.org for healthcare professionals. You can go on the website and you can find that information. Also, Patient Central, like I mentioned, can be contacted at phone number 877-272-6226. And you can also find them, like I mentioned, at patientcentral@pancan.org. Now, there's a few big programs that we call out at PanCan. Know Your Tumor, like was mentioned earlier in some of the program. Know Your Tumor is a precision medicine service that provides patients and their oncologists with information about patients' biology through tumor tissue, biomarkers, testing the genetic testing for inherent mutations. Knowing Your Tumor gives patients and their healthcare team access to information about treatments, including available clinical trials. And they are personalized to that individual, for them personally. PanCan patients who are able to go through therapy and match their tumor biology live an average of at least 1 year and longer compared to patients who don't. So another program that's offered, one of the bigger programs, is Survivor and Caregiver Networks. We know peer-to-peer and one-on-one support matters. PanCan Survivors and Caregivers Network connects patients and caregivers with peers who know what they're going through, who have experienced it themselves. Now, professional advice and guidance matters on this journey a lot. That's very important. But so does talking with someone who's been where you are and who has gone through the same thing themselves. These personal connections is so important, and it really helps individuals get through, similar to me. And if I have time in the end, I'll love to share a little more about my story. Now, there's a patient registry also. The patient registry is a global online database created to look for patients in treatment, side effects, management, and diagnosis that will lead to improving treatment options and outcomes for patients. When patients join this community and share their experience, they give researchers access to critical data that help make discoveries. Whether they're patients and caregivers, the contributions are meaningful. Together, we have more pancreatic cancer research moving forward. We have 5 volunteer affiliates here in Florida, which is Jacksonville, Central Florida, down in Orlando, Tampa, Broward County, Palm Beach, and Miami. Now, our volunteer affiliates is the reason that PanCan call itself a national organization. They bring the work out to the communities across our country. The affiliates work with raising awareness, advocacy, survivor, caregiver engagement, media and communications. There's education and outreach. The raising funds through the Purple Stride events, and the affiliates are volunteers driven, and we're always looking for more volunteers to join our effort. You know, 5 years ago, my wife was diagnosed with pancreatic cancer. And that's when we first got affiliated with PanCan, and they gave us a lot of information. She wound up, after being diagnosed, living 3 years after that. And I made her that promise that I would stay involved and do whatever we could do to help people that are affected by this deadly disease. And that's why I'm involved with this organization. This was my high school sweetheart. We were together for 36 years and friends for 44. So I want to do everything we can, and PanCan is an awesome organization, is pushing this effort to make improvements on the survival of this deadly disease. If there's any questions, I'm not sure if there's anything else I can add to that. We can turn it back over to Doctor.
Raymond, thank you. That was a really nice overview of PanCan, and thanks for sharing your personal story. It always hits closer to home. But I know you've, you know, the years that I've been involved with PanCan, you're a Jacksonville staple for PanCan. So thank you for all you do for the organization and for our patients.
Sure, glad to be involved.
Thanks, Raymond. So let's see, can we move the slide? Yes, okay. So I just wanted to touch on disparities. It's really important to bring this up, and because cancer affects populations differently, particularly minority groups in the United States tend to bear a greater burden for many cancers for a number of reasons and a number of ways. Flasco is actively fighting cancer disparities on many fronts, and Flasco wants to help narrow the gap, and this is really important. So to learn more about cancer disparities in pancreatic cancer, please download our Flasco's Disparities in Pancreatic Cancer slide packet and Minority Cancer Awareness handout located in the handouts drop box on your GoToWebinar panel. So I really love that we included that in the program, and that's something that's very important to me and should be important to everybody. So without further ado, we are going to move on to the question and answer portion of the webinar, which I've been looking forward to, and there is been some great questions. So I would ask the other panelists to please turn on their cameras. And let's start with the first question. All right, so the first question looks like, I guess maybe I should, I'm gonna scroll to the top here. So there was a question in regards to, I have global pancreatic tumors. What surgery would I qualify for? So, you know, I'll be honest, I don't know exactly what's being referred to in terms of global pancreatic tumors, if that's pancreatic tumors that are scattered about, I suspect. The role of surgery is limited in the stage 4 setting. So once the pancreatic cancer has spread, most of the time it's to the local lymph nodes in the liver and also to the abdominal wall, more rarely to the lung or the bone. You know, the role of surgery is less well defined. And it's not that we don't want to do surgery. It's not that the surgeons can't do surgery. It's that we want to make sure that patients benefit from surgery. Interestingly, Dr. Modi had to, unfortunately, he had to leave, but we do appreciate his participation. He is helping do a protocol looking at stage 4 pancreatic cancer and how we can make a difference maybe with radiation, not quite surgery, but I don't know if that answers the question, but surgery has a more limited role in stage 4 or metastatic, or I think what's being referred to there is global pancreatic tumors. Dr. Hussain, anything to add there?
I agree with you. It's understandable if somebody has cancer, they would want to have it removed. But what we know about the disease is that sometimes, most times, there's microscopic disease that you just cannot see. And even if you see 1 or 2 spots that may be easily removable, you know, we have many patients with colon cancer, for example, where we cut out liver metastasis. in patients with pancreatic cancer, people have looked at this, and what happens is that if you cut them out, many times you just see more lesions popping up. And what that does is that it deprives you of the opportunity to give something which could be beneficial or effective in that period of time. And if you have a complication from surgery, that can really be detrimental, and you may not be able to get back to treatment. So really, I always give the story, and I'm not sure if one of my long-term surviving patients is still on the call, but I have patients who make it for a few years, or even one who I'm referring to for almost 10 years now without surgery. So it doesn't necessarily mean that you have to go through surgery to have a good long-term outcome.
Yeah, well put. And those stories that Dr. Hussain is alluding to, and patients who do well for many years, keep us going. And so, again, there is hope out there for this disease. So next question is, how common is pancreatic insufficiency following a Whipple procedure? A very appropriate question given the discussion that we had. I think something that's under-recognized, under-diagnosed. It can happen, the literature suggests, up to 80% of the time. Definitely, there's varying degrees of it. Some people have more severe symptoms, some less, but it can be a real quality of life, detriment. And some patients will say, well, I don't go out to eat because every time I don't feel good and I go to the bathroom right away. If it is pancreatic insufficiency, we can help that with some pills that replace the enzyme. So if you're having those symptoms, please bring it up to your physician and bring up the topic of pancreatic exocrine insufficiency. They actually refer to it as EPI, exocrine pancreatic insufficiency. But Dr. Hussain, anything to add there?
Yeah, so one of my, I like to give anecdotes, but I like it. One of my longest surviving patients post pancreatic surgery, about 4.5 years out, started losing weight and was very concerned that he may have had a recurrence. And it turned out that I had moved away from where he lived. And it turns out that he had pancreatic enzyme insufficiency, and it was not recognized and it wasn't being treated. So not just in that setting, but even in patients where you're going through chemotherapy and you're having a difficult time putting on weight, it's really important to replace the enzymes. And I depend heavily on our dietitian and our GI folks who can really help us with these issues. And I have some patients who take very, very high doses of pancreatic enzyme replacement to maintain their weight, and it can make a difference in symptoms and nutritional status and overall health. So it's extremely important.
Yeah, I love the antidote, and that some patients have trouble gaining weight after the Whipple, and sometimes that's the issue. Yeah, just have a low threshold to talk about it. I really like this question. I like all the questions. This one's very appropriate for the time. So the question is, some researchers are studying cancer in general as mitochondrial metabolic disease and looking at ways to block cancer cells' energy pathways. Is there any application for pancreatic cancer? Well, Dr. Hussain and I would echo, I'm sure, the same. So there was just a phase 3 clinical trial that finished accrual very fast because we're desperate for trials in this disease. And the drug is called devimistat, and it actually also called CPI 613. I'll quiz you on that later, actually. And it blocks the metabolic pathway in the cell and affects the way that the cell metabolizes glucose. And so that's kind of exactly what this participant was alluding to. The drug just got FDA fast-tracked. It got, is that right, Peter? FDA fast, I think fast-track would be the term, which means that the FDA has it on their radar, and we're awaiting the results of the phase 3 trial to determine this might be, we need a positive trial so badly in pancreatic cancer. this might be it. I don't want to speak too prematurely. We'll have to wait for the results, but I think exactly what this participant was alluding to here. Peter?
No, I don't have anything to add. I agree with you 100% that this is an approach that, you know, targeting metabolic pathways in general. There are a lot of people working on that, and the drug that that Jason mentioned is the one that is in the lead right now, and we're hoping that we see some positive results from that.
Fingers crossed. We need it. So I'm going to let Dr. Hussain field this question. If I enroll in a clinical trial, is there a chance I could get placebo and then my cancer goes untreated?
So it is unlikely that a patient with advanced pancreatic cancer will be enrolled in a placebo-controlled trial. You know, what the studies that are ongoing right now, for example, in the CPI 613 trial, if I recall correctly, that study gave patients FOLFIRINOX with the experimental drug or a placebo. So what happens usually is that you have some standard therapy, and the new therapy or the experimental therapy is added onto the standard therapy. So there are many studies that are testing FOLFIRINOX plus something else, or gemcitabine Abraxane plus something else. And for example, if you were treated already with chemotherapy and you come onto a second round or a second type of chemo that we refer to as second line, the approved medication in that setting is a drug called Onivide. So if you were going to try to make inroads for that group of patients, you would do a study where one group will get the standard, which is Onivide, and then the other group will get whatever is experimental. And you will at least get some treatment. And even, you know, patients who go through the standard lines of therapy, generally speaking, we look for phase 1 clinical trials, and usually those are not placebo controlled. So, you know, I don't think anybody will give something someone who has an active cancer a chance of being randomized to placebo unless there's no other option that exists for that situation. You know, there's some cancers where there are no drugs approved, and it's considered to be acceptable to say, okay, well, we'll test one thing compared to nothing or compared to supportive care and see if it makes a difference. But in pancreas cancer, if you're going to get frontline treatment or even second line treatment, there's a standard that you will at least get plus something else, or at least get randomized to the standard. So I have not participated in these studies where I've seen patients get a placebo as a kind of a control.
Yeah, I don't. That was wonderfully put. I don't have anything to add to that, but yeah, it's pretty rare these days to get just a placebo. It's more common to get the standard of care plus the study drug versus standard of care by itself. Yeah, placebo trials. You know, I think patients are less and less comfortable with getting a placebo. Understandably, I would be too. And from the Dr. Hussain fan club, Camille Moses says hi. So you got a fan club out there giving some shout outs. All right.
Camille is a long so she's the one I was referring to.
Awesome. We love it. All right. So next question. Are there any COVID specific patient assistance programs? Ooh, I really don't, I don't know that I'm equipped to answer this one. I don't know if it's referring to if you've had COVID and you have complications thereof, and you also have cancer, or if it's just COVID. So I don't know that I'm going to be able to answer this one accurately.
It's clarified a little bit further down. It says,
is it?
Clarification for the COVID question, pancreatic cancer patient assistance for those suffering from the burden of the pandemic, financially self-isolation.
There we go. Thank you. All right. So there, and so this leads into, you know, patient advocacy. And there's actually a video by Dr. Diaz that we're going to share with you and email out, talking about these kind of support programs. Now, what I usually recommend is that with most physicians' offices, there are miracle workers called social workers, and they can help put you in touch with programs like the American Cancer Society. Florida Cancer Specialist has a wonderful patient assistance program, and you don't even have to be a Florida Cancer Specialist patient, which is, I'm really impressed with how they did that. So there is, Flasco has a foundation, so you can reach out to Flasco. So there is a lot of ways to get help, and it's really important that you have an advocate for you. And typically that ends up being a social worker. They're amazing. Some offices have like a financial assistance person, but there are a lot of options. Peter, I don't know if you know of any other ones that I didn't mention or anything like that.
So I think a lot of institutions are trying to do things to help patients in this situation. And for example, at our center, we have a monthly Zoom bingo event where we raise money. And it's sort of fun for patients and to interact with the physicians. And we also raise money for patients who are in need, who need money to come to the center or for whatever. So in one event, we raised $1,400 and we gave it to a family that was really in need. And I know that there's some foundations like the Seema Magowitz Foundation who does something similar to that. So, I think PanCan may have some resources on that, and maybe, I don't know if the PanCan representative is still on, but, again, our social workers are involved in this as well. They may be able to guide patients in terms of psychological support and even some financial assistance programs.
Yeah. Oh, there we go. Hey there.
Hi.
Okay. Did you want to comment on some of the, yeah.
Yeah, I was just going to say, like Peter mentioned, one of the things that Patient Central can provide for folks is a list of those types of resources that might be tailored to your geographic area, your specific situation, right? If you have a certain type of disease, if you're being seen at a certain type of center, or again, if you live in a certain area where there's a local foundation or something that you might be eligible for because of where you are. So that's definitely something that would be in the resources that you would receive when you contact Patient Central. Just let them know that that's something you're interested in. Hope that's helpful.
Awesome. PanCan to the rescue again. So next question is one that we get a lot. How important does diet play in fighting cancer, improving prognosis? For example, plant-based versus keto. Oof. I am probably not qualified to answer this to the extent of from a basic science standpoint. My answer is kind of a little bit general in that everything in moderation. You want to stay away from, simple carbohydrates. You want to stay away from processed foods. You want to stay away from, so much, things with tons of added sugar. You want to eat close to the earth, fruits and vegetables and lean meats. And that's kind of my approach. We don't have data yet to suggest that plant-based versus keto really makes a difference. Now, we are writing a protocol at Mayo looking at like a fasting, what we call a fasting mimicking diet. There's some suggestion that maybe it augments the immune response, but I don't know that for sure. And so I don't want to send patients down a path of fasting and maybe not feeling well and it making them feel worse when I don't have good, solid data. Peter.
Sure, so I can comment on that as well. So it's a controversial area, when patients are diagnosed, you want to do everything that they can, of course, to try to help and control what they put in and that kind of thing. So what we are very careful about is that there's some people who try to do things that can actually adversely impact their nutritional status. So a lot of people try to avoid carbohydrates completely and they end up losing a lot of weight. So I usually advise patients to have a balanced diet. I have some patients who want to go to a completely plant-based diet, which is okay. But you have to make sure that you're still getting enough to support your metabolic requirements, because I've seen people who go on a very, very strict or restricted diet where they lose weight, and you really need to be able to maintain weight and stuff like that for many situations in pancreas cancer. So we, again, rely heavily on our dietitians. And, the question about plant-based or intermittent fasting and stuff like that, I think there's some data, scientific data, to support a plant-based diet, but I don't think that you have to do that exclusively. In terms of intermittent fasting, there's some data, preclinical data, experiments that show that it may be beneficial, and we still don't know enough really to recommend it widely. So, I applaud the Mayo Clinic for doing that study. I think it's a very important study.
Yeah, and I try to take an approach of, I don't poo-poo it. If I kind of will talk through it with my patients and try to understand where they're coming from, what their goals are, is it safe, and if it doesn't sound unreasonable, I typically support it. Even if I don't have the evidence and the science. And I'm sorry, Catherine I didn't introduce her, but she popped on and saved the day there. She's with PanCan, so along with Raymond. So let's see here. Are we going till 8? I believe so. Yeah. So we have a few more questions. One is, my sister has stage 4 pancreatic cancer and I have exocrine pancreatic insufficiency. Should I be concerned that I can probably have the possibility of cancer as well? So I always emphasize during, this kind of forum that, can't offer real medical advice specific to your care. I would ask your physician why you have exocrine pancreatic insufficiency, and if the physician can give you a reasonable answer for why that is you have it, then that can give you some reassurance. If it hasn't been explained why you have exocrine pancreatic insufficiency, I would ask your physician to investigate further. I'm going to let Dr. Hussein, if you don't mind, field, I believe, this last question. The last question is, what can a patient do to complement chemotherapy or other standard of care therapy? So along the same vein, but this also refers to exercise, supplements, so on and so forth.
Right, so we get this question very commonly, and I am a big proponent of cardiovascular exercise. So we know that patients who are physically active tend to tolerate treatment better, and they overall have better outcomes. So there are a few different scenarios, right? If you have a patient who has advanced pancreatic cancer, they're usually dealing with a lot of fatigue from the disease itself and from the treatment. And really one of the few things that has been shown to combat fatigue from cancer from chemo is exercise. And it's sort of paradoxical, because you think, well, if I'm already tired and I go and try to exercise, that would get even worse. But we see this over and over. Patients who start off doing 5 minutes on a treadmill or 5 minutes on an exercise bike today, and then by next week they're doing 10 minutes, and the following week they're doing 15 minutes. They feel better progressively, right? And a lot of times with the disease, you get cachexia, which is sort of a muscle wasting kind of problem, and the chemo can cause muscle weakness and neuropathy. So keeping those muscles active and keeping your body moving really can fight against what the disease is trying to do to your body. So that's one scenario in somebody undergoing active treatment. Now, in patients who have completed treatment, in remission from their disease, this is very, very important. So in cancers like breast cancer and colon cancer, it is very well described that keeping a healthy diet and exercise and trying to maintain a good body weight that can actually be as powerful in terms of preventing cancer recurrence than actually the chemotherapy itself. So we look at what happens when you're sedentary is that you create this, for want of a better term, a kind of inflammatory environment in your body, which is sort of a good milieu for cancer to come back. But if you can stay active, have a healthy diet, maintain a good weight, that kind of decreases some inflammatory markers in the body and also decreases certain hormonal levels, which actually decrease the risk of cancer recurrence. So we encourage patients, we have an exercise program that we recommend for patients receiving treatment. And you don't have to go into a specialized exercise program. Simple things like, like exercise bands, cardiovascular exercise, just walking outside really makes a big difference. So I'm a big advocate for staying as active as possible.
Yeah, I would echo exactly that. I encourage patients to be as active as possible, as tolerated, and build up that endurance. And it's kind of hard to get that activation energy going, but once you do, it just kind of is a self-fulfilling, prophecy where you're just feeling better overall and just better mindset. It helps with the mental health as well, which is critical with this disease. So I think last question here, actually one more. Is it possible to get a massage while on chemo? Absolutely, go for it, treat yourself. But yeah, no problem with getting a massage. Now, one thing I will mention, if your blood counts are a little low, most of those places are really clean. Everybody's wearing a mask these days. I don't see any problem with it. I would say enjoy. You deserve it. All right. I think that's it for questions here. Great. So to wrap things up, I definitely would like to thank an effusive thank you to all of our panelists for their presentations and thoughtfulness and contributions to this evening. I know I've learned something. I hope you have during the webinar. Flasco would also like to thank PanCan for their partnership on this Living with Pancreatic Cancer educational program. I know they've been participating for as long as I've been involved in this webinar and session. As a reminder, all of the handouts mentioned in this webinar can be found in the handouts drop-down box on your GoToWebinar panel. So make sure to download them now if you can. And additionally, the webinar was recorded. So if you missed anything and you want to hear it again, it will be available on the Flasco website soon. So on behalf of all of us, and I would like to thank you for joining us this evening, and hope to see you in the future. And keep waging hope, as PanCan's motto is.
Hello, I'd like to welcome you to the advocacy portion of our Flasco Living with Cancer series presentation tonight. My name is Michael Diaz, and I'm a medical oncologist and hematologist. I'm the Flasco Director of Patient Advocacy and a past president of Flasco. I practice medical oncology and hematology in St. Petersburg, Florida with Florida Cancer Specialists. And we're here today to talk about something that's pretty near and dear to my heart, and it has to do with patient advocacy. And so first of all, I'd like to start off more from the big picture perspective. I've had people tell me in the past, well, Mike, talk about advocacy. Tell them what it means. Well, I looked up the definition of advocacy in the dictionary, and all it says is to advocate. Very helpful, huh? So let me just explain. So advocacy, as far as I'm concerned, yeah, it's a general concept, but it means to advocate for, which means you're trying to do something to benefit somebody, whether it be yourself or somebody else. In fact, you all being here tonight to educate yourselves means you're advocating for yourself in the form of education, educational advocacy about a condition that might mean something to you or someone you know or care about. So yes, there's educational advocacy. Your doctors will also most likely advocate for you whenever they're fighting insurance companies to get scans or medications or therapies or testings approved. We really don't get paid any money to do that, and that's we either have to hire staff to do that, or we do a lot of it ourselves too, but we're advocating for you. The way, and there are many other ways besides education. You can advocate for family members. You can help assist with certain components of their care, and all that is advocating. There are lots of ways to do that. The main way that I like to advocate for my cancer patients, because that's one of the reasons why I love being a doctor. In my free time, which is not a lot of, but I do spend a lot of time doing it, is I advocate for my patients when it comes to healthcare reform. One of the things that I noticed as I was going through my training as a young oncologist is that it didn't seem to me that there were a lot of healthcare providers involved with the policy decision-making process that would impact patient care, patients' healthcare, or their access to care. And one of the things that I've been doing since I've been practicing medicine for a little over 15 years now, I've been getting more and more involved with advocating for healthcare reform so that patients have access to affordable quality healthcare that's close to home. I'm a firm believer that we have enough resources in this country. There's no reason why people shouldn't have to spend their life savings or refinance their house just to get their cancer care. I think it's ridiculous. I personally think that the system is flawed in a lot of ways. And I think that there are a lot of people who are getting a disproportionate share of the resources, and those are not the patients, and I personally don't think they're the providers either. So that's one of the reasons why I'm involved with healthcare reform. And we do it in a lot of ways. I work with organizations of like-minded individuals, whether it be other oncologists or pharmacists. We have organizations. We work to advocate here in Glasgow, mainly at a state level and also at a national level. But I do work with other organizations for synergy. And it all has to do with in understanding the healthcare system, which is extremely overly complicated. It needs to be fixed, but it's what we have, and we have to understand it to understand where the problems are so we know where we can fix things. So if we need to, instead of guessing, we will perform studies or commission studies to be done to better understand the little nuances of how potential things are impacting patient care or access to patient care. And then we also spend a lot of time educating our elected officials on this process, whether it be local in Tallahassee, whether it be going to DC, which we don't do a lot of traveling now, but I previously I would go to DC at least twice a month to help educate our elected officials there. We have to network a lot with Health and Human Services as well as Center for Medicare and Medicaid Services. And at a state level, we have to work a lot with the governor's office, the insurance commissioner, as well as Florida Medicaid for a lot of patient issues. And just to give you an idea of how effective you can be sometimes, for those of you all that aren't aware, about 4 years ago, the previous administration attempted a demonstration project that we will call the Part B Medicare Demonstration Project. And they thought, oh, we're going to save money. We're going to reduce the cost of care. And unfortunately, all it would have been doing was restricting access of care to possibly 50 to 75% of Medicare patients across the country, because it basically refused to pay for the more expensive treatments. Well, if you have cancer, you know that a lot of the time, the most effective treatments are the more recent treatments and are going to be the more effective treatments. Well, they were going to try to encourage you to use more generic medications. Well, the generic medications in cancer care are over 10 or 15 years old, and they're fairly outdated and not usually as effective as the newer medications. So it would have negatively impacted patient care. We went to grassroots across the country. We had to have all of our patients contact their representatives and their senators and tell them that they needed to shut this down. We were very successful in that it never took place. In fact, the following year, I went to meet one of our senators' healthcare aides, and she said, you don't need to introduce yourself to me. Because of you, I had over 3,000 emails in my inbox. My email was locked. My email account was locked for several weeks. She said, you did a great job with that. The senator wasn't listening to me, but when he saw how many people were concerned about this project, he said he realized he had to listen. So we can work together, and we'll talk more about that. I would like to move the discussion onto a more timely, more relevant, more current issue, which is known as pharmacy benefit managers. And most people aren't aware of even what a pharmacy benefit manager is. And just to give you a little background, the pharmacy benefit managers are who your insurance companies hire to manage your oral prescription benefits. They started off as just claims processors back in the 80s and 90s. All they would do is process insurance claims for oral medications. Well, over time, they evolved, they coalesced, they merged to the point to where there are essentially 3 pharmacy benefit managers that manage the oral prescription benefits for nearly 80% of all Americans. That's a lot of control and influence. Well, what happens when you have this control and influence? Stay tuned, we'll talk more about that. But these pharmacy benefit managers are so lucrative from a business perspective that they are merging with the top largest insurer companies in the country. In that one of the largest pharmacy benefit managers, CVS Caremark, recently bought one of the nation's largest insurance companies, Aetna. Well, 3 of the largest pharmacy benefit managers are owned or own some of the top 4 largest insurance companies in this country. So there's a lot of vertical integration going on. And it's because this component of healthcare has become so profitable. It's like, well, why has it become so profitable? Well, these pharmacy benefit managers, and more we're learning about this. In fact, this gets us to something that's near and dear to my heart, the price of drugs. I think the price of drugs are crazy. They're astronomical. They're very high. And it's difficult for patients to get their care because these newer medications and treatments cost so much. Well, studies are showing that when it comes to brand name drugs, we don't even talk about generics. It's a lot more complicated. Brand name drugs, probably well over 50% of the cost of any drug, whether it be oral drug or IV drug, over 50% of that is going to somebody else as a rebate. Yes, over half the cost of drugs. So if you're on a drug that costs $1,000 a month, over $500 of that is going to a rebate in somebody else's pocket, not the pharmaceutical company's pocket. So a lot of people like to complain to the pharmaceutical companies about drug prices, and I'm not letting them off the hook. But when I meet and I talk with a lot of the senior national executives in pharmaceutical companies, and they're aware of my stance that drug prices are too high and they need to get them under control and they need to do something about it. But part of the reason why the costs are so high is because of these rebates that are given out. Well, these rebates are from the drug companies, but they have to be built into the cost of the drug. And one of the nation's largest recipient of rebates are these pharmacy benefit managers and or insurance companies. Yes, the U.S. government via Medicaid and the VA healthcare system, they get some rebates. And they are a decent sized percentage of those rebates, but nowhere near as large as the rest of the rebates. In fact, some studies are showing that well over $150 billion a year in 2019 dollars was spent on rebates. And that's one of the reasons why the cost of drugs are so high. And when I talk with the senior people in pharmaceutical companies, they are somewhat traumatized after they have discussions with these pharmacy benefit managers because they have to talk with them and set up contracts before the pharmacy benefit manager will make their new medication available to the lives that they cover. And this is a typical comment I hear about that a pharmacy benefit manager would tell a pharmaceutical company. Wow, we really like that drug, your new drug. It's great, and we'd love for our patients to have access to it. But they need to know that we're working for them. So up front, we want you to give us a 10% discount off of the price so they can see we're working for them. And then after they've paid their copay, and after all the claims have been processed, on the back end, we want a 50% rebate. Otherwise, they will not even know your drug exists from us. And so these guys, they want their drugs to be available. And like I said, 3 of the largest pharmacy benefit managers control nearly 80% of the prescription benefits. If you don't let them have what they want or some version of it, your drug's not going to see a lot of patients or not even have the possibility to be used for a lot of patients. So there's definitely an issue with the rebate system going on, but also on the other end, the pharmacy benefit manager will also go after the providers. When I say the providers, the pharmacists, or in the case of cancer patients, if the cancer doctors are providing the drug, even the oncologist. They like to come back to us about, months after the transaction occurred, i.e. the prescription was given, and they'll just come back and say to the provider, either the cancer doctor or the pharmacy, and say, yeah, you owe us 10% of all this money. And it's like, why do we owe you 10%? So, well, you didn't meet quality measures. And this is exactly what was told to my practice. You didn't meet quality measures. Like, we didn't know that there were quality measures. They said, well, you're correct. There's not any oncology or cancer specific quality measures. So, we looked at the cancer patients that you're taking care of, our cancer patients that you're taking care of, and we looked at their adherence rates to blood pressure medications, diabetes medications, and cholesterol medications. And well, they were all perfect and they were adhering to the medications. So we couldn't use that data. So we looked at the entire Southwest Florida regional adherence rate to blood pressure medications, to diabetes medications, and cholesterol medications, and we applied that to you. And because the compliance rate in Southwest Florida is not very good, you've got to pay this penalty. And, my people know that if we don't pay this, what's called a DIR fee, direct and indirect remuneration fee, then we get kicked out of network. We can't take care of our patients. And trust me, if we can provide the oral medications to our patients, they will have much better patient care than if it's provided by some third-party specialty pharmacy that's nowhere near here, that knows nothing about patients or patients' care. So we do what we can on our end to try to sustain those fees. But those are just examples. Now, that's how they affect the business end of thing. That's how they affect the pricing end of thing. But in order for these pharmacy benefit managers to make more money and to steer more traffic towards certain products, they develop these formularies. And these formularies are, I guess you could say, their versions of preferred drug lists, and that drugs that they like, and some might even say, yes, that might be the appropriate indication for the drug, but are they getting higher rebates on this drug, and that's why they like it or not? We don't know. All that information is privileged and considered to be proprietary. But they have these formularies, and we're seeing perfect examples of how these formularies that they're trying to implement on cancer patients, they don't really work. You have cancer, you know that you may have other unique healthcare conditions, and it's not like there's a plethora of medications with which you can choose from, which some might consider to be your best treatment option. Why? Because different medications have different adverse side effects, and some may have an adverse side effect profile that may be detrimental to you given your unique health characteristics, or may not be better for you given your unique cancer. And so it's very difficult to say that just because I have cancer and it is cancer type X, that you should always start off with this one medication that these pharmacy benefit managers are saying you should start off with. And I can give you a perfect example. Let's tie it into patients. One of the things that we do is that we collect what's called patient PBM horror stories. And I do want you to know, if you have had any of these horror stories, as I will be talking about in a minute, please type in the little text box your name so that we can, and the best way to reach you, so that we can reach out to you at Flasco and get your horror story recorded. We do this at the Flasco level. We do it at a national level. I do it with a national organization I work with called Community Oncology Alliance. If you go to pbmabuses.org, that's P as in Paul, pbmabuses.org, you can see, unfortunately, volumes of horror stories that have resulted from these pharmacy benefit managers negatively impacting patient care. Just to give you an example, getting back to the formularies that we were talking about, we have several examples that have even happened here in Florida where a patient with a condition and other cancer and other medical conditions, for example, like bad kidney disease, should be getting, if you look according to routine formularies and what's considered to be the number one line of therapy, a medication that its number one side effect is that it can impact the kidneys. Okay, well, one of my partners saw this patient and realized, wait, this patient needs this medication. It could impact the kidneys. They have bad kidneys. Then maybe we need to start them on the second line medication first, period, and avoid this potentially more dangerous one. They sent the patient to a local cancer center of expertise, and their specialist in this cancer said, yeah, you can't have that that first drug, that first medication. You need to start off with the one second on the list because it could hurt the kidneys. Well, it took the pharmacy benefit manager over 2 months to approve the medication because it was denied because it wasn't number one on their formulary list. So we have several examples where they can delay access to timely care. We even have examples nationally of patients just dying while they're waiting for their medication to arrive. An unfortunate example of a patient who waited 9 weeks for a routine metastatic breast cancer medication to arrive, but the pharmacy benefit manager fought with the provider for so long, the patient gave up after 8 weeks, went into hospice. The medication showed up just after that, but the patient was too weak to even take the medication. We have other examples of where the pharmacy benefit manager, I have 2 examples in my practice, not with me, but with 2 of my partners, of where the pharmacy benefit manager actually said, no, we know this medication is front line and is the first one that's listed to be used, but we think the patient should have surgery first. And in both instances, even the surgeon and the medical oncologist said, no, surgery is contraindicated in this patient. They said, well, no, we think the patient should have surgery first. So they're making a medical decision without even seeing the patient. They're making a medical decision without a license to practice medicine. And that's one of the things they're doing to save money and to help their bottom line. These guys are businesses. They took an oath to their shareholders. They did not take an oath to patients like the doctors did. And so if you have a horror story, please type it in on the question box so that the people from Flasco can contact you, hear your horror story so we can get it documented. We need to have these documented. And part of the reason why is that we are working on trying to reform the healthcare system as far as these pharmacy benefit managers are concerned. We're working both at a state level and at a national level. To give you an idea of what we've been doing at a state level, in fact, we've been coordinating with other healthcare advocacy organizations, and we attempted to have legislation passed last year for pharmacy benefit managers. It would have held and made sure there was transparency as well as accountability, because right now there's no transparency. I was in DC a couple of years ago and was talking with some key staffers on both the Senate and the House, and they said, yeah, the pharmacy benefit managers people were up here yesterday and they were lighting their hair on fire saying, oh no, we can't be transparent. That will disclose proprietary information. We won't be able to save money. There's no way we can be transparent. Well, this is healthcare. Everybody needs it. And if you have to be that transparent, then is there a reason for that? So we want reasonable transparency and we wanted accountability. And unfortunately, that bill did not pass. It did not go up for vote in the House or the Senate, but we will be working on that again for next year. And that's one of the reasons why I want to grab your attention. We will be working on that next year, and we will need your help with reaching out to your legislature, your state representative and your state senator, so that they will know they need to support this bill. Now, with that being said, to give you a little bit more of an idea of how conniving these pharmacy benefit managers can be, one of our other organizations developed a study looking at Florida alone, just to better understand how these pharmacy benefit managers worked in the Medicaid system that's run by the state. And just in one example, with a generic medicine, they saw that the pharmacy benefit manager was paying a pharmacy that they didn't have a preferred contract with. They're paying this pharmacy approximately 20 cents a pill for generic medicine the patient needs to take twice a day. And they were paying a pharmacy that they had a contract with. Now you got to keep in mind, this contract that they have with the pharmacy is not accessible to the public. Why? Because it's proprietary. Well, they were paying them $10 a pill. And when you sit down and you look at things, it would not be reasonable, given the fact this medication is taken twice a day, every day, within a year, if you assume a reasonable number of patients are on this medicine, it's a commonly used medicine, very commonly used medicine, that it wouldn't be reasonable for there to be a $30 million discrepancy going into this preferred pharmacy's pocket. So that has caused a lot of uproar in Florida. That was not able to get this legislation passed, but it was able to get the governor to hire a nationally renowned actuarial firm to do their own study to validate and verify what this other study has seen. If there's that large of a discrepancy, then if it's the taxpayers' dollars, I think the taxpayer deserves to know, why is this pharmacy getting paid so much more for pill than your average pharmacy? Okay, that stuff needs to be known. There's been a lot of reform going on at the state levels because of little tactics like this, especially in Florida, especially in Ohio and Georgia. We want Florida to be next, and so we'll be reaching out to you to advocate more next year. We're also working at a national level in DC with a couple of different bills, a couple of pieces of legislation, one so that patients could get their drug within 48 hours and they wouldn't be waiting several weeks or even months to get their medication. Now, some of that stuff's been put on hold because of COVID, but we plan on bringing that up at the beginning of next year, because right now, with the way things are in DC, not a lot's happening at all within the next several months because of COVID, because of the elections, but we are working on it as we can. So your involvement is essential. As I told you with the example, when it comes to healthcare reform, if your elected official hears about you, the voter, and they hear that you are concerned, they will listen. And we are planning on this next year, for this next 2021 legislative session, we are planning on having a bill introduced to help reform pharmacy benefit managers. But we need to have a coordinated effort, because there might be more than one bill out there. We want to make sure that you are sponsoring the correct bill. We want to make sure that you know why. So it's a good idea, I think it would be, if you are interested and want to help verbalize your opinion as a voter to your elected officials, that you put your name and email in the question box. Let them know you want the monthly newsletter. It's a monthly patient newsletter. That's one way to stay updated. Not only will you learn about advocacy issues, but you will learn updates about all the different things that we talked about today. And just as well, you can go to the website at www.patients.flasco.org to learn more about not only advocacy information, the things that I'm talking about here today. Once again, it's to make sure there's a coordinated effort so that you know when to reach out to your elected official, you know what to talk about, you know which bill to tell them they need to support, but it's also to learn more about other things for patients, such as assistance programs, various support groups, as well as clinical trials, and yes, of course, something important and dear to me, information about advocacy. And also, we plan on notifying all the patients that have participated in these Living with Cancer series when there is a time we need to call them to action, because you can help us, the providers, make sure that you have access to care that's affordable, quality, and that people are not taking all the money that's being designated for healthcare, instead of it going to the patients, they're putting in their pocket. We got to put a stop to that. So I appreciate your attention, and please sign up for the newsletter, go to the website. Any questions, once again, please direct them in the question box. Your questions will be answered, but you all have a great evening. Thank you. God bless.